afternoon, or good morning, depending on where you're joining from. And thank you so much for taking time out of your day to join us for today's webinar. This is a national webinar presented by SAMHSA's GAIN Center with the support of SAMHSA, the Substance Abuse and Mental Health Services Administration. And today's webinar is on treating people who use meth or other stimulants, leveraging contingency management in criminal justice settings. And our presenter for today is Dr. Richard Rawson, and I will introduce him shortly. So I am Dr. Melissa Stein, a Senior Project Associate at SAMHSA's GAIN Center and Policy Research Associates. And you will see a chat box at the bottom of your screen, or a chat box icon. If you want to share where you're joining from, who you are, and where you're joining from, we would love that. I really appreciate everyone chiming in already in the chat. It's just wonderful to see how many folks are joining from across the country. I personally am joining from outside snowy Charlotte, North Carolina, and I can't believe I'm saying that. So before we start the presentation, I'll cover just a few more introductory items. So first, the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the U.S. Department of Health and Human Services. And if you have any questions in regards to the presentation or for Dr. Rawson today, please type them in the Q&A pod. That the icon is found at the bottom of your screen. And at the conclusion of the presentation, we will cover as many of your questions as time permits. We'll also be conducting a couple of polls throughout the event and appreciate your participation. You should have just seen a poll pop up, and we really appreciate if you just click and submit your responses. We are recording this webinar, and the recording will be made available on SAMHSA's YouTube channel following this event. We will also be disseminating slides to everyone who registered for this event following this webinar. A certificate of attendance will also be available for download at the end of today's webinar, and I believe we may also be able to make it available by email to everyone who attends. Please note that the certificate is for your personal files. We are not able to issue CEU credits. And we do have ASL interpretation for today. Our interpreters are Pamela Mitchell and Kip Opperman. And we also have live captioning for today's event. So to view live captioning, just click on the more icon at the bottom of your screen. You should see a live transcript CC button and then be able to navigate from there. So before we get into the presentation, we are delighted to have someone from SAMHSA to provide some opening remarks. Dr. Robert Ballew is a physician and senior advisor from the Substance Abuse and Mental Health Services Administration, and we really appreciate his time today providing some opening remarks. Dr. Ballew.
Hello, and thank you, Dr. Stein. My name is Rob Ballew, and I'm a physician and senior advisor here at SAMHSA. And over the past several years, it's been my privilege to work on issues related to contingency management. And in this way, I've been very lucky to get to know today's esteemed speaker, Dr. Richard Rawson. Stepping back, nationally, we've seen a tremendous progress in expanding access to medications for opioid use disorder across jails, prisons, and treatment courts. But what we've also heard is a consistent question from communities across the country. What evidence-based treatments are available for stimulant use disorders? This question has become increasingly urgent as stimulant use continues to rise in many regions. To this end, SAMHSA has taken significant steps to address the gap. In January 2025, just over a year ago, SAMHSA released new guidance that fundamentally expanded access to contingency management for SAW and TOR recipients. This advisory, through which everything was announced, increased the allowable incentive value from $75 to $750 per patient per year. While this is currently limited to SAW and TOR grantees, This tenfold increase represents a major commitment to making this evidence-based intervention more accessible and effective, particularly for treating stimulant use disorders, where we currently have no FDA-approved medications. SAMHSA's guidance provides clear frameworks for implementing both prize-based and voucher-based contingency management models, along with the necessary safeguards to ensure these programs operate with the fidelity to evidence that's required. This is the kind of concrete support that communities need to move from interest to implementation. We're really fortunate today to have Dr. Rick Rawson to help translate this policy change into practical application. And Dr. Rawson, thank you for being here. And with that, I'll turn it back to you, Dr. Stein. Thank you again.
Thank you very much. And now I would like to take some time to briefly introduce our speaker. Dr. Richard Rawson is a research professor at the Vermont Center for Behavior and Health at the University of Vermont, and he is professor emeritus at the UCLA Department of Psychiatry. And he has conducted numerous clinical trials on pharmacological and psychosocial behavioral addiction treatments for the treatment of individuals with opioid, cocaine, and methamphetamine disorders. And he has led addiction research and training projects for the United Nations, the World Health Organization, and the US State Department. And he's a member of the Motivational Incentives Policy Group, a volunteer group working to reduce obstacles to the use of contingency management for the treatment of stimulant use disorders. And he currently provides technical assistance to 8 states on the development of treatment services for individuals with stimulant use disorders. And we really appreciate his time today because, as we've recognized, there are many of you who have worked with us here at the Gain Center on increasing access to medication for opioid use disorders, but we recognize that stimulant use remains a need. Treatment for stimulant use remains a need. So we greatly appreciate Dr. Rawson presenting today. Before we go to the presentation, we'll just take a look and see who is joining us for today's presentation. It looks like about nearly half, 43% of you joining from urban locations, 30% joining from rural locations, and 27% from suburban locations. And we do have a small but important proportion joining from reservations, pueblos, or Alaska Native villages. And in terms of organization or background, let's take a quick look. I believe the largest proportion of you are joining from corrections, probation, or parole at 31%, followed by 19% of you joining from community-based provider organizations. And I believe that's followed by about 15% of you joining from a government or a policy organization. So we greatly appreciate all of you joining us for today for this important topic. And without further ado, I'll turn it over to Dr. Rawson.
Thank you very much. Let me see if I can. Yeah, I have a story to tell, which is about how we have tried to get contingency management more widely used in the U.S. As Rob mentioned, contingency management has had a tremendous amount of data research for over 30 years demonstrating its effectiveness, but it hasn't been used. And in about 2019, Dr. Wesley Clark, who was previously the director of CSAT and is a addiction psychiatrist and lawyer, and I were talking about what we could do to try to get contingency management used more widely in the United States, because I've been doing addiction work since the 70s, starting in about 1980. My work has been almost exclusively around cocaine and methamphetamine use disorder and developing treatments for people with those disorders. And over that time, we've done all kinds of interventions. I think I still have the indoor record for the most negative trials of medications that we have tested. I haven't been doing that for a while, but for much of the 1980s and 90s, I spent time doing medication testing for stimulant use disorder. People are still very actively doing that. But over that whole time, there's been one intervention that has clearly shown to be have robust positive effects, and that's contingency management. So my story today is going to be how we've gone about getting contingency management into greater use, why we've been getting it into greater use, and then the part about criminal justice settings is more of an aspirational discussion. We have a great deal of reason to think it could be very useful in those settings, but there's not been much data yet on the effectiveness or how to go about doing it. It's not will it work, it's how do we get it implemented in a population. But let me give you a little bit of data. I'll go through some of this fairly quickly and try to get to what you're interested in as quickly as possible. Wesley and I, as I said, started talking in about 2018 or 2019 as these numbers started to really go up that you see at the right side of this slide. And these are the drugs related to overdose deaths in the United States. And as you can see, the two drugs driving the overdose crisis as of right now are fentanyl and stimulants. And if I was to project this out another 5 years to what we're seeing now, there actually has been an overall reduction, a significant reduction in overdose deaths, which has been a great thing to see, a very positive development. However, the role of stimulants within overdose deaths has continued to increase. Depending on where you are in the country, it can be anywhere from 50 to 70% of people who have overdose have stimulants as part of the reason for their overdose. These data that were presented by my colleague, Joe Friedman, who was a UCLA medical student, looks at which drugs have played a role. And as you can see, as of the last data point, which is 2021, the blue part of the bar are those overdoses with fentanyl only. The purple was fentanyl plus stimulants. The red is stimulants only. And the top tan part are neither. So if you add the red and purple parts of the bar together, you see about 50% of overdose deaths involve a stimulant, either cocaine or methamphetamine. In general, the numbers for methamphetamine have been higher because it's the primary stimulant in most of the United States, except for the East Coast, Northeast, where cocaine still is very prevalent. This gives you some data by state. I won't go over this, but as you can see, all the states show the final bar dot on this graph is over 45% in all the states are showing stimulants involved in overdose deaths. So it's been a problem that has escalated in recent years. As I mentioned, we have one treatment. We have no medications yet. There are some medications that are currently showing some promise. There's a great deal of interest in the GLP-1 drugs, and there's a lot of research going on. However, we've been looking at medications, as I said, since my first study. The first published study I had on a medication trial was in 1981. I published a study in the Archives of Internal Medicine showing that dizipramine did not work for treating people with methamphetamine use. And then we've had hundreds of studies since then with very similar results. But we are hopeful that we will get a medication. But let's talk about contingency management, because that's what we do have that works. And we've got very robust evidence on this. CM is a behavioral technique employing the systematic delivery of positive reinforcement for desired behaviors incompatible with drug use. So in the treatment of stimulant use disorder, generally we use vouchers or gift cards that can be earned for the submission of cocaine or methamphetamine-free urine samples or for other target behaviors. And certainly contingency management has also been used for people with opioid use disorder to improve their adherence to their medication, not as a direct treatment per se, but as a way of getting improved medication adherence. So in that case, contingency management is used to reinforce medication adherence according to a doctor's prescription. But what we're going to talk about today is its application for people with stimulant use disorder. Here are the essential ingredients. You have to pick a behavior. That you have specific behavior. A behavior is not an attitude. A behavior is not an intention. A behavior is a measurable event that you can clearly and objectively measure. You need to be able to measure the behavior. When the behavior occurs, you need to be able to provide tangible incentives immediately. And tangible incentives, that is more than verbal reinforcement or attaboys or other kinds of symbolic reinforcement. What we're talking about here are things that the person is interested in receiving, they value, they're interested in earning, and so that it will help to motivate that behavior. If the person does not demonstrate the target behavior, they don't earn the reinforcer. However, they're not punished, they're not scolded, they're not criticized. The whole contingency management intervention is a positive intervention. And I think it's important that, yes, these incentives, these gift cards that we provide are the active ingredient, but it's given in a context of positivity, a context of reinforcement and support and empathy. So CM is a non-drug reinforcer that's used in exchange for evidence of drug abstinence for the most part. That's the primary protocol we're going to talk about is people earning gift cards for giving urine samples that are negative for stimulants, that are tested in a point of care test cup and immediately reinforced. So these small incentives, although they seem very modest, produce a tremendous effect if used effectively. Now, as we've started doing these trainings and promotion of contingency management around the country, there have been a lot of people who say, oh yeah, we're already doing contingency management. We give people coffee and donuts when they come to our group sessions, or we give a certificate and we have a party when people graduate, or we give people candy bars when they show up for their, all of those things are absolutely wonderful. They're valuable, they're useful. I encourage you to have as much positive reinforcement in treatment as possible. However, they're not contingency management. Contingency management requires a specific protocol, and that protocol has certain specifications that are important to be used. So I certainly am not at all discouraging people from using incentive programs, but it's important to know the difference between a general incentive program and contingency management, which is much more structured. So a protocol based, and this is distilling out the several hundred studies that have been done on contingency management for stimulant use disorder. What we're talking about in an evidence-based protocol is one that uses an adequate level of reinforcement. Rob mentioned earlier that there was a $75 limit on the amount of federal money that could be used to provide contingency management. That was not an adequate amount of reinforcement. $75 for a treatment episode is inadequate, subtherapeutic. It would be like giving people 2 milligrams of buprenorphine and saying, well, we're using buprenorphine, but it's at a subtherapeutic dose. Similar with contingency management, you have to use an adequate dose, and the level of reinforcement is very important. You have to use it for a duration. contingency management is not a one-time event or a two-time event or we do it once a month or we do it once every 3 months. It has to be done over a period of time with frequent target behavior measurements to be able to provide frequent reinforcement. When using contingency management, you're handing out gift cards. As Rob mentioned, right now, in the federal limit on contingency management for federal money is $750 per patient per year. There are other programs using non-federal dollars, opioid settlement dollars, for example, where some people are using protocols up to $1,200 per patient per year, which is certainly something that can be done. But in order to do that, you have to follow the protocol. There are some fraud prevention guardrails that are important to the Office of the Inspector General that make it critical that these guardrails are followed. And I'll talk about those in a minute. But that's another of the essential elements. There needs to be a well-designed training and implementation plan. In many cases, we've seen in many instances around the country, people saying, oh, we're going to do contingency management. They read a couple of articles, they put something together that's well intended, but it's not really contingency management. And so the training is important. And once the person or the people are trained, there needs to be a plan for implementing contingency management. How to do it, what are the obstacles, what are the challenges, and that has to be carefully considered. There need to be variations for specific populations and settings. Most of the research done with contingency management has been done in substance use disorder treatment programs. There's increasing amounts being done in primary care. And we're now talking today about seeing if we can move this into settings where people are being, people with criminal justice involvement can receive contingency management. And it's important to deliver contingency management according to the protocol with fidelity. That is, everybody's doing the same thing, and we know that the protocol is being followed, and you can demonstrate that. These are some of the guardrails that are important for fraud prevention. I won't go over all of them. You can get these slides, but there's an issue about advertising that you're giving out incentives as part of treatment. That can't be done. People can advertise they're using contingency management as part of their treatment program, but there's a ban on or sanctions for putting up billboards saying we'll give you stuff if you come to treatment. So that has to be considered. These other ones, following a research protocol, documentation, making sure the incentives are given out according to the protocol. All of those things are important so that this has to be a serious intervention that is clearly defined, clearly delivered, and followed and measured with fidelity. As I said, contingency management is a positive approach. It's reinforcement, it is not punishment. One of the things that has gotten a little bit confabulated over the years, when I was first working with contingency management in the early 2000s, that was about the same time that drug courts were taking off, and there were sanctions and rewards that were part of the drug court, and people started thinking, well, if we're doing this with rewards, this must be contingency management. And so there was a perception that the drug court model is a contingency management model. It's related, but because there's a punishment component in the drug court model, there are sanctions. There are no sanctions in contingency management. Contingency management is a 100% application of positive reinforcement. So there's an encouragement, a positive reinforcement. Even when people come in and give samples that are positive for cocaine or methamphetamine, they're given verbal reinforcement, verbal encouragement to continue to participate, to continue to come back. and some suggestions for how they might get a negative sample the next time. It's a very positive approach. And once you attach a punishment to any part of the contingency management, you're no longer doing contingency management. And that's one of the areas that's gotten a bit confused. I'll click through these quickly. I just said, as I said earlier, there's a lot of research supporting contingency management. This is a study done by the World Health Organization and colleagues looking at the research on all treatments that have been done for treating people with cocaine and amphetamine use disorder. This was published in 2018 by a very esteemed group of researchers who do meta-analysis of large data sets. They looked at 50 studies, 7,000 participants, 12 different approaches, and their conclusion was the combination of contingency management and the community reinforcement approach was the most efficacious and most acceptable treatment, both in the short and the long term. Now, community reinforcement is a treatment that has been added to contingency management and can extend the benefits of it. But the initial period of getting drug use stopped and getting people getting their drug use reduced has really been the function of the contingency management. Another more recent study was published, and this was on methamphetamine use disorder, published here in the US. Contingency management intervention was the only one that showed strong evidence for reducing stimulant use. This study also found some effect of cognitive behavioral therapy. Even more recent study was done with people with cocaine use disorder. This one, in the meta-analysis, only contingency management programs were associated with reduction in cocaine use among adults. My colleagues at the University of Vermont did a meta-analysis of treatments that are applied to the stimulant use of people on MOUD, people who are taking methadone and buprenorphine for their opioid use disorder, but they're also using stimulants. This study looked at interventions to reduce that stimulant use and found that only contingency management had evidence and that it produced benefits in a variety of different ways. So the research is overwhelming. And I won't go through any more of these. Recently, the American Association of Addiction Medicine and the Association of Addiction Psychiatry did a analysis of treatment and wrote guidelines for treatment of cocaine and methamphetamine use disorder. Their summary basically said contingency management is what's recommended. It's the current state of the art. It's currently the most robust treatment we have. Okay, why haven't we been using contingency management? Well, there's a variety of issues. Certainly, when I was doing the work in the early 2000s, this attitude that we shouldn't be paying people to not use drugs. Well, that's not what we're doing. We're providing reinforcement for negative urine samples, and that's presented in a contingent way. It's an accountability that patients have to give a negative sample in order to earn whatever the reinforcer is, the gift card that's there. And it's set up in a systematic application of a protocol. But there have been some resistance around that issue. I have to say that was a big deal 20 years ago. As I go around the country now and talk to groups about this, it certainly appears that there's a much greater acceptance of the idea. People are much more interested in what works rather than does this fit their idea of what treatment should be. And certainly there's no denying that contingency management works. The federal funding issue wasn't a limitation. Now people can use, as Rob said, SOR and TOR money up to $750 per patient per year in a designed evidence-based protocol. There's been some confusion about whether the Office of the Inspector General views this as a kickback. They do not, as long as you follow the guidelines. As long as you have a protocol, you follow your protocol, the protocol provides reinforcement that it is effective at an effective level, and that you're not advertising that you're giving away stuff as part of treatment. There's been an absence of effective training. There have been a number of even recent initiatives where there's been a training, people have been told, here's contingency management, go do it, and nothing happens. There's more to it than that. There needs to be a training and an implementation that provides support and guidance as people are delivering it, and fine tuning to how to best set this up and how to best operate it. We certainly don't have 100% clear picture of what the most optimal protocols, or protocols and parameters, but we're getting a better idea. What the biggest obstacle right now for many people is funding contingency management. The SOR and TOR funds are available. That is, every state has SOR and TOR funds. I think every state has them. But within every state, providers have to go to the state agency or go to SAMHSA to get an approval for a protocol. Nobody has really filled out that whole procedure yet. Rob may have some more recent information than I do as to whether or not SOR and TOR funds are being used, but they can be used, but they haven't been used extensively yet. What is being used is opioid settlement funds. There are now at least 10 states where opioid settlement funds are being used to fund contingency management. Vermont was one of the first. Michigan now has a project with this. Connecticut has a fairly good-sized project going on. And these are really good funds to use for this because there's a lot of flexibility. You can design a protocol at an adequate level of funding with this. Some states have used state money because you can use state money without the limitations of the federal restrictions. Some states have gotten an 1115 waiver. That is, the state Department of Health or whoever is responsible for their Medicaid agreement with the federal government has submitted an application to the Center for Medicaid and Medicare designing how they're going to use Medicaid dollars for contingency management. California's done this, Washington's done this, Delaware's done this, Hawaii is in process, Montana's done this. However, it's a pretty big operation. It's a pretty big undertaking. But California did this, was the first state to do this in 2023. And as of now, the last I heard, over 12,000 people have been admitted to contingency management in California under this waiver. So the waiver is a very powerful way of getting contingency management, but it does take some work and does take the state agency to get involved and apply for this waiver. Other groups have used foundation money. I would say right now, the SOR and TOR funds and opioid settlement funds are probably the two most rapid ways of going about getting funding for contingency management. There's some protocol questions that have to be answered, and these are some of the issues. I won't go over these in detail. I do have to say, if you're going to use urinalysis as the metric, that's the target behavior, giving a stimulant negative urine test, you need to use point of care test cups because the reinforcement has to happen bang. You come in, you give the urine sample, it's tested negative, you get the gift card. It can't be that you get the reinforcer next Thursday when we get the results back. That's one of the issues that has been somewhat of an obstacle. And there are all these other things that have to be considered as part of protocols. Want to just mention this California project and go through this quick. California's had a major stimulant, mostly a meth problem for 30 years. And the director of the Department of Health in California in 2021 decided they started to see increase in methamphetamine related overdose deaths, and she decided she wanted to use the most effective treatment. She didn't care what all the obstacles were or what all the excuses were for not doing contingency management. She said, what's working, and let's do it. And she submitted an application to CMS. They got a waiver. They had a group that designed the protocol, which included CM experts and providers and other people from the state of California, and designed a protocol to be used across the state. The preparation of the sites was intensive. The training and then ongoing coaching calls that go on for months after the startup, because there are always glitches that come up that need to be problem solved. So the California protocol is 24 weeks. It is starts with people earning $10 for a negative urine sample. They come in twice a week for 12 weeks. And the amount increases if they give consecutive negative urine tests. They get to end of 12 weeks, it switches to once a week, $15 or so per urine test for another 12 weeks. So it's a 24-week protocol. California has a $5.99 limit to its protocol, and the $5.99 came because there was a belief that this might be taxable income, and if you gave more than $600 or more, there would need to be a tax notification given to the person. That's just changed. That $5.99 has changed to $2,000. So I think for most protocols that are going to be used, evidence-based protocols, this is no longer an issue. I believe if it was that situation in California 4 years ago, we would have probably gone with a $1,200 protocol rather than a $5.99. $5.99 has been borderline in terms of the amount. I think we could have gotten people's better retention if we'd used higher amount, but this has been pretty good. I'll show you some results. The incentives are earned if people give these point of care tests negative for stimulants. And we only are looking at stimulant use. If they're using opioids, if they're using benzos, certainly they meet with a counselor and talk about MOUD if it's an opioid or other treatments. But the CM is only applied to the stimulant use. And one of the things California has done that really has been a tremendous benefit is they've hired a company that takes care of all the distribution and tracking of the incentives. There are a number of companies that do this. California has used a company called Q2I, but it clearly has made it much easier for staff to keep track of it, to do it properly, and to follow the protocol. This just gives you a quick shot of the rates. So this is, people can earn, by the end of 12 weeks, if they've done it perfectly, which nobody does, they could be earning $50 a week over the first 12 weeks. As you can see, in the second 12 weeks, they earn less. And I'll go through this very quickly. In the system we use in California, there is, they can earn gift cards. I'll skip over this for a minute, come back to it in a minute. This was the training and implementation program. And it was the group at UCLA did a great job with this. As I mentioned, the incentive manager company automatically calculates the amount of the incentive to be given, disperses it to people on an electronic debit card or electronic a gift card in California, and it tracks all of the interactions. And so you have a completely tracked program, which is great for fidelity measurement and for the OIG fraud prevention guardrails stuff. These are some of the gift cards that are delivered electronically to people. If they don't have phones so that they can't accept them electronically, they're given a paper copy. All of these gift cards are at sites that do not sell alcohol. People can't use the cards for alcohol, tobacco, lottery tickets, or something else. But so you can get restrictions on these and make sure that they're generally used for positive things. Here's some data. I'm going to go through these data because I want to get to the criminal justice discussion. This is this was about a year ago. I apologize for that. This presentation was prepared over a year ago, but there have been a variety of delays. But it's now over 12,000 that have been admitted into California, maybe above that, as far as I know. This is what we've gotten from this is retention data. Completed 24 weeks, about a quarter of the patients. Completed 12 weeks, but not 24 weeks, about 40%. So about 2/3 of them complete at least 12 weeks. And about a third of that group complete 24 weeks. Partial response, 28%, and non-response, about 9%. And again, this is with a $599 24-week protocol, which is a lot. What people actually earn is about half of the maximum. The average participant earns about $300 over 6 months of participation, which is not a lot. They earn about $50 a month in general. I think if we used a higher incentive amount in California, we would get much better retention. Not sure we get much better urinalysis data, because the urinalysis data is pretty impressive. 96% of the tests are negative for stimulants. However, if somebody has used yesterday and they know they're going to give a positive test, they often don't show up. So if you count missed tests as positive, then the rate is 74%. But in summary, what you're seeing here is people who are in treatment on an average of about 16 weeks. During that time, 3/4 of their urine tests are negative. Now, I've done a lot of treatment with people with stimulant use disorder over the last 50 years. We don't have any treatments that produce that kind of results, that retain people that well and that reduce their stimulant use that well in a large group. The patients like it. They say all kinds of positive stuff. The staff still likes it. The staff, many of whom were skeptical about the use of this odd technique. I mean, part of it's the difficulty in getting it implemented is that it's an odd technique. It's like, it's not counseling exactly. It's not a medicine. It's this interaction, which people tend to think of as being just a transaction. If you go into the clinics and you watch contingency management being delivered, it's very clear that it's this interaction produces a very powerful connection with patients and is very helpful in getting them participate in other treatment activities. And we have all kinds of patient testimonials that I won't go into here. And I want to get to the aspirational part, the part about using it within the criminal justice population. Because as I do these talks around the country, this is the population people are most interested in. As Rob said, you've done a great job getting medication for opioid use disorder out there. We now have an evidence-based treatment for people with opioid use disorder, which has now been adopted in many places within jails and prisons and drug courts and pre-release and all sorts of settings like that. If you think of contingency management for stimulant use disorder as the parallel to buprenorphine and methadone for opioid use disorder. The question now is, how do we use the benefits of contingency management with that population? And this is, as I said, this is an aspirational talk. This is here's something that really works. Let's figure out how to get it used for this population. That's where we are with this at this point. My colleague, Michael Prendergast at UCLA, did a study in, about 20 years ago now, where he wanted to work with the LA County jail population and encourage them to participate in treatment when they were released. He did a bunch of stuff in the setting itself. And then when they came out, they got a $50 incentive for showing up for their first session. And that was Michael's definition of contingency management. Unfortunately, that's not contingency management, and it didn't work. And the data from this study were negative. Now, what the point of that is that if you're going to do contingency management, do contingency management. A half program or a one piece of the idea of contingency management, or mushing contingency management or some elements of contingency management with a bunch of punishment elements, is not contingency management. And Michael has showed quite definitively this didn't work. CM is an intervention that uses positive reinforcement. And it looks like I spelled positive wrong, but and using it in a drug court setting, if it's used together with drug court, and we're doing that now in Burlington. I'm not doing it. Christine Hayner at the Howard Center in Burlington is doing this. And Christine has been a real advocate for using contingency management with this population, because she sees that there's a tremendous need for working with stimulant use disorder. And the preliminary experience we're having is very positive. But somebody's in a drug court program. They're coming in, they're doing their activities, they're going to their groups, they're getting urine tested. All of that is done, and all of that information goes to the judge as part of the drug court. Contingency management is done separately, it's done independently. People come in and give point of care urine tests. If they're negative, they earn the gift cards. If they're positive, they don't earn the gift cards. But regardless, the data doesn't go to the judge. The data for the contingency management is independent. Now, obviously, if you're going to do that, it's going to take the right judge to agree to that as a stipulation. But it's not presented as part of the drug court. It's an additional intervention. So the two things have to stay independent. And the point of care, so the point of care test results are only used for the CM. They're not used as part of the drug court data. Using CM for attendance in an in-custody treatment sessions with no contingent linkage to post-custody treatment has no effect. That's what Michael showed. Michael did a bunch of incentives in the jail and then said, if you come out, you get this one thing, but nothing after that. That doesn't work. However, I think that what Christine has done here in Vermont, in Chittenden County, and working with the pre-release patients there, is people coming out of the incarceration meet with Christine one time while they're incarcerated, and she explains contingency management to them and gives them an explanation about if they come from incarceration to her treatment program in Burlington, they'll earn $25 reinforcement. In fact, by meeting with her in the incarceration, they actually earn $25 there. And if they follow it up with a visit to her, they actually can earn $50 upon release. So we want to give them, we can't give them the card while they're incarcerated, but they can be told you have credit when you come to us. And if you come in and attend, you'll get another $25. That's to try to increase that showing up. Christine was talking about the very poor rates of showing up following release from incarceration. And so far, her data, she's been doing this for 6 months now, and we're getting a much higher show up rate and ongoing participation. Then they go into a standard 24-week contingency management program on an outpatient basis, because contingency management is an intervention designed and researched to be used on an outpatient basis. So the way we are looking at it in Burlington is they get this pre-visit, they get told they have credit, that they just need to show up. They can get credit, and they can get even more credit for showing up. And then if they start giving negative urine samples, they can continue to earn $25 a session. This looks very promising at this point. We've talked to other groups around the country that are interested in doing this. There's been a group in West Virginia that's talked about getting it started, and many others. It does take the right judicial environment for judges who are willing to give this a try with it being independent of the rest of the treatment court or treatment requirements for the court. But I think it has real potential. What we know is this treatment works, and we know that this is a population that desperately needs treatment that works. And we particularly think the California data is showing something interesting. It's showing that we get really good results if people who are being discharged from residential treatment into outpatient treatment are started before they get discharged into the community. If you start them and move them right into contingency management, the relapse rate post residential rehab is very low. You get tremendously beneficial effects. I think the same thing is potentially very true with starting people who are leaving incarceration and providing this robust contingency management as they move into the community. There's some references. One I did not put here is one done by a colleague at UVM that I will send to the GAIN folks. Eli Klemperer published a study less than a year ago on what are some of the challenges for using contingency management with a criminal justice population. And I think Eli summarizes some of the challenges and some of the potential solutions to this. And so I'll stop there.
That's wonderful. Thank you so much. Let's move to the next slide. We'll just close up, wrap up. So SAMHSA does have a document online in I believe they're calling it now the SAMHSA library. So if you search in your preferred browser for SAMHSA advisory on using SAMHSA funds to implement evidence-based contingency management services, then you should be able to find this resource online. Thank you, Sam. Sam just dropped the link in the chat if you want to access it directly from the chat. Let's go to the next slide. And we also will be sharing a certificate of attendance for those of you. You can also click on the link in the chat to download that certificate of attendance. And for those of you who've been asking, we at the GAIN Center are not able to issue CEU credits, but we do know that some folks are able to use this certificate to obtain credits through their accrediting body. So check on that, but we are not cleared to issue any credits through the GAIN Center. But if you want to download the certificate of attendance, please go to that link in the chat. Next slide, please. And we do have a poll that just popped up if you are interested in providing any feedback to the GAIN Center. And let's go, there we go. So 2 more webinars coming up this month. Okay, a big shift in topics. So for those of you who are in our competence or civil commitment processes, we have 2 webinars coming up covering Virginia's model of how they conduct competence evaluations, as well as ensure quality as people are undergoing inpatient treatment. So 2 events coming up February 18th at 3 p.m. Eastern, and then another event on February 25th at 3 p.m. Eastern, both of those covering different aspects of the Virginia model. So I hope that you can attend. And if you, for those of you asking about the certificate, if you will just scroll up a little bit, the link for the certificate, oh, Brianna just dropped it there. Okay, and next slide, please. If you have not signed up for GAIN's listserv, here is a condensed URL. Just type that into your preferred browser. It'll take you to a page where you can sign up and opt in to our quarterly newsletter. And we share programs, individuals doing interesting work, all focused on behavioral health and criminal justice. Next slide, please. And then finally, if you would like to be connected with more information, if you would like to be referred to Dr. Rawson or other experts that are working in this space, or if you just want to reach out directly to the GAIN Center, here is our website as well as a toll-free phone number. We welcome you to reach out to us for more support. And Dr. Rawson, I just want to say thank you so much. Yes, it has been a year in the making, so we are so excited that we have concluded this webinar, and I know that everyone has benefited from it as much as we thought that they would. So thank you for your time and all of the expertise that you shared today.
Thank you very much.
All right, then I hope you see all the chats that are coming in.
I do. Thank you. You're welcome.